Medical Computing, CIBC seminar. Today we are very pleased to have Alison Marsden here, who is assistant professor at the University of California, San Diego. She's in the mechanical engineering department there. She received her bachelor's degree from Princeton and then her PhD from Stanford. She then did a postdoc with Charlie Taylor, who many of us know, in cardiac biomechanics, which is her area of specialty. And we're very happy to have her come here. I met her at an NSF Career Award, which she has received. She's also received a Burroughs Welcome Award for science at the interface. And I met her at the NSF Career panel, where they had a few of our more senior people give talks about science and career, and then to the actual NSF career awardees. And I was very interested in her work, and I thought there was potential for collaboration, so invited her out to share with us some of her research, and that we can also share some of our research with her. So please join me in welcoming Alison Marsden.
Thanks, Chris. And I'm excited to be here for more than one reason, because I'm staying the weekend to go skiing after this, which is why everybody wants to come here for seminar in February, I guess. So I want to talk about some of the work going on in my lab at UCSD. And I am going to be talking about, sorry, this thing is coming off my ear. Our work in simulation-based treatment planning in pediatric cardiology. And so I'm going to go over some tools for patient-specific modeling and some of the challenges that we encounter on the computational side and sort of interfacing with clinicians. And so when I talk about patient-specific modeling, I'm referring to the process of starting with medical image data. And in our case, we're modeling the vascular system, and we're particularly interested in modeling blood flow. So I'm going to be talking a lot about CFD simulations of blood flow in arteries and veins. This is a picture of angiography data taken from a patient who was born with a severe congenital heart defect, and another figure of a simulation of blood flow that we did for the same patient. And so, of course, our goal is to go from imaging and clinical data to a patient-specific simulation, and then ultimately to extract some clinically relevant information from the simulation that can then feed back into having a positive impact on patient care. Sorry, I don't know what's going on with this.
It unfortunately doesn't fit all ears well.
Yeah. Okay. So I wanted to sort of give a little history lesson before I delve in. The reason I'm going over this is mostly to illustrate the tight coupling between cardiac surgery development and engineering that's gone on since the 40s and 50s. So the very first heart surgery was performed in 1944 by a team at Johns Hopkins. This is Alfred Blalock here. The first surgery was called the Blalock-Taussig shunt, and it was performed on blue babies, congenital heart disease patients. And after that, the first open heart surgery was performed by Walt Lillehei at the University of Minnesota in 1952. And so this picture here illustrates the need for a later engineering invention, which was the heart-lung bypass machine. So this picture is showing the patient submerged in an ice bath, which they required to induce hypothermia to cool the patient to protect their brain function long enough to do the heart surgery. And they got about a 10-minute window from this. So any more complex surgery that they wanted to do would require the patient to be on a bypass machine for much longer than that. So there was a history of this team at Minnesota working with engineers, and this led to the development also of the pacemaker. And this also came about because of the congenital heart disease patients that they were working on at Minnesota. And there's a funny story about the first pacemaker, which is that it had to be plugged into the wall. So before they had battery power, the patient had to be plugged into the wall. So they would, in order to transport the patient from, say, the OR back to the ward, they actually had a nurse running down the hallway, plugging it into the next outlet, and then wheeling the patient down, and then plugging it into the next outlet beyond that. Okay, so like I said, this need to induce hypothermia and protect brain function then led to the development of something called the bubble oxygenator, which then was a predecessor to the heart-lung bypass machine that we use now. And again, this came from the interaction, very close interaction of clinicians with engineers. We had the first MRI imaging done in the 70s, and this is a picture of the very first cross-section of a mouse thoracic cavity with MRI, and the first implantation in human of a stent in the 80s, the mid-80s. There have obviously been a lot of advances in imaging since that time, so we're now able to get very high quality and detailed anatomic information from imaging. And this is showing you MRI imaging in the brain, so cerebral vasculature. This is MRI of a patient following Fontan surgery, and I'm going to talk about this. And this is CT imaging of a patient with Kawasaki disease, and I'm going to talk more about our simulations of this disease. So obviously we can get all of this great anatomic information, but we can't use imaging as a predictive tool. Okay, so that's really where the simulation piece that we're working on comes into play. So what we want to do is have simulations as a predictive tool so that we can predict the outcomes of surgeries, so we can test different surgical designs, test different device designs. And so you might ask yourself, well, we have all this great imaging, but what can fluid dynamicists or engineers contribute to cardiovascular medicine if we can already see the anatomy in this great detail? And the answer is, well, I'm being a little facetious here, but these are the Navier-Stokes equations. And as an engineering community, we have a lot of experience implementing and solving these kind of equations for predictive design capabilities, right? We want to solve these equations to predict the lift over an airfoil. And so we're trying to make parallels here with cardiovascular medicine. And so we're applying a set of common tools such as optimization, uncertainty quantification, the need for boundary conditions, analysis of flow physics, and robust design tools. And we're trying to translate a lot of these tools from more traditional applications. So this is a figure from my PhD work where we were working on optimization to reduce the noise coming from hydrofoils caused by turbulence. And we're trying to take a lot of these tools and now look at things like, can we predict blood clot formation in a patient? So while I would say patient-specific modeling has a huge potential to impact clinical care, I would argue that we're about maybe 30 years behind the aerospace industry or other industries that have really adopted simulation as part of their design workflow. I'm going to go over a few of the main challenges that we face, and then after that, I'm going to give you two examples of specific diseases that we're working on where I hope that we are impacting clinical care. The first challenge is that of image segmentation and model construction, and part of the reason I'm bringing up some of these challenges is that I think there's expertise here at SCI where we can collaborate. So this is a model that we've built of the pulmonary arteries. This is the main pulmonary artery, and then branching into left and right with about 60 or so branches. And an example of automated segmentation just in 2D of a slice of image data. I think we all know, anybody who's worked on image segmentation knows that the automated tools often break down, and so we end up doing a lot of hand segmentation to build something like this. So I'll talk a little bit more about, we're facing the challenge of how do we how can we do more high throughput simulations of a large number of patients if we have to do this kind of manual intervention. Meshing is another challenge. So we have very complex geometries. We often have geometries with very different length scales. So we might have, say, an aorta with coronary arteries coming off of it, where the coronaries are very small and we need to mesh them with high accuracy. So we usually use adaptive meshing. We are currently using a commercial mesh generation tool, which I am interested in replacing with an open source alternative. This is just an example of one of our meshes in the pulmonary arteries, where we've done mesh adaptation to the flow, and so you can see that the mesh elements have aligned themselves with the flow direction. And as I mentioned, this need to use adaptive meshing in models with disparate length scales. I think probably the biggest challenge in simulating cardiovascular blood flow is that of the boundary conditions. So one reason is we might be interested in predicting the postoperative conditions. We take the preoperative image data, we perform some kind of virtual surgery, and we're interested in predicting the post-op conditions. And so you need a set of boundary conditions that will adapt to the postoperative conditions when you don't have the measurements. We want boundary conditions that can account for the dynamics of the circulatory system. And we want boundary conditions that give us a realistic physiologic response. I'm showing here sort of the range of different modeling methods we can employ, going from lump parameter models that are circuit analogy models to 1D wave propagation models to 3D finite element models. And so one of the things that we're interested in doing is taking a 3D model like this and then using some of these lower order models as boundary conditions. So I'm going to go over how we do that. So for example, this might be the outlet of one of our 3D models. And beyond that outlet, we may not be able to see with adequate resolution in the image data, but we know that there's a tree, a vascular network beyond the outlet that looks something like this. And so we might want to, say, construct this tree and compute its impedance and use that as a boundary condition. And as an example of the influence of boundary conditions on the flow, this is a comparison of, so this is a simple model of a bifurcation with a stenosis or narrowing in one branch. This is a 75% area reduction stenosis. So what happens if you use zero pressure outlet boundary conditions, which I still see a lot of papers coming my way that use these type of boundary conditions. I would argue that these kind of boundary conditions are wrong for any time you have multiple outlets in your model. And the reason is this, right? This is showing the way that the flow distributes. So if you apply a zero pressure outlet boundary condition to both of these outlets, you're going to get a 70-30 flow ratio. If, on the other hand, you apply a resistance condition, which is a ratio of pressure and flow, you get a 50-50 flow split between these two outlets. Okay, this one is more physiologically correct. If you look at experimental data about stenoses, you see that you only really get a reduction in flow at about 90% or greater stenosis. Okay, and then the other thing to notice here is that you can get physiologic levels of pressure. So this is pressure in millimeters of mercury compared to the zero pressure case. Okay, so when we prescribe outflow boundary conditions in our 3D models, we've mostly been looking at these three choices. You can impose a simple resistance, like the example that I just showed you. So imposing a ratio of pressure to flow. You can impose an impedance condition that allows you to model wave propagation more accurately than the resistance case. Or what we've been doing lately is to use a circuit analogy. And so you construct a lump parameter model out of these various circuit components that you put together. And you can then model the circulatory system as a closed loop. So to give you a visual idea of what this might look like, this is a model from Charlie Taylor's lab of an abdominal aortic aneurysm. And we might be imposing the flow rate as a function of time at the inlet, and we can usually get this from MRI data. So this is phase contrast MRI data imposed at the inlet. And now we've imposed an RCR Windkessel model at all of the outlets of this model. Okay, and then all of these outlet, the values of these resistors and capacitors have to be tuned somehow to match the clinical data of the patient. So we would need something like a blood pressure measurement. We need to know how the flow would typically distribute to these different outlets. When you do this kind of lump parameter modeling, we make an analogy between the circuit element and the fluid mechanics. So a resistor, the analogy is to the laminar pressure drop. Capacitor, we make an analogy to the vessel distensibility. So the vessels can store flow and then release them at some later point in the cardiac cycle. Inductors, we make an analogy to flow inertia. Diodes can act as valves. And then we have other functions, such as elastance functions, that can model the contractility of the heart. So this is an example of the kind of multi-scale modeling that we've been working on in our group. And this is actually a closed loop model of the circulatory system in a patient with a single ventricle heart defect. So this is actually a model of the Blalock-Taussig shunt, which is the first heart surgery that I mentioned at the beginning. This is the aorta here, and we have a shunt that's inserted in the surgery that connects the systemic side to the pulmonary side. And this is basically to provide oxygenation to the baby until they can do the later stage surgeries. So what we need to do is solve this coupled set of equations where we have the Navier-Stokes equations solved in the 3D model, which is in this domain here. And then we have a set of ODEs that describe the rest of this circuit. In a very simple case like the RCR model, we actually know the solution to the ODE, and you can just hard code the solution right in your solver so you don't have any numerical issues. In this case, when the circuit becomes more complex, we actually start to run into issues of numerical stability and how to do this coupling. And so one of the things we've been working on in my lab lately is developing algorithms that allow us to couple these systems in a stable, accurate, and modular way. So there are a couple of different ways to do this kind of coupling. One of them is to do it monolithically. So you have your Navier-Stokes equations, you have your ODEs, you solve the whole system as a coupled system. There has been some success doing this, although usually this leads to very ill-conditioned systems, and this is not really the approach that people are going with. On the other extreme, you can do it completely partitioned, in which case you do it fully explicitly, so you pass information between the 3D domain and the 0D domain at every time step. And this is the way that groups have been doing it with commercial solvers like Fluent, so they code up the LPN network in a user-defined function, and then you can run this system. But it's, of course, severely time-step restricted because the coupling is explicit. It has the advantage that you don't need to go into the Navier-Stokes solver to change anything, but yeah.
So the approach is often used in fluid vector interaction problems, so can you gain insight from some of the advances that they made there in terms of predictive corrective type schemes and such?
Mm-hmm. Yeah, so I'm going to show you what we ended up doing was coming up with a way to keep the modular structure but using implicit coupling. So I believe the algorithm we came up with actually takes advantage, uses the best, sort of best of both worlds, in that we can use the implicit approach from here but keep things modular. From a programming point of view, we can change the LPN without recompiling the flow solver, which is attractive. So I'll show you a little bit about what we need to do in that case. So we have our 3D domain up here. We're solving the Navier-Stokes equations to obtain velocity and pressure at every point in that 3D model. We then want to pass flow rates at the boundaries to the ODE model, and then pass the pressure back from the ODE domain back to the 3D domain. And this is, for example, if you want to use a Neumann boundary condition, if you want to do Dirichlet, the arrows go in the other direction. And we can do both in a stable way. So basically what we do is within every iteration of our linear solver, every time the linear solver iterates, we pass back and forth the pressure and flow information. And then we've tested doing this with either fully implicit, meaning you change the left-hand side matrix of your system, or semi-implicit, meaning you don't always update the left-hand side matrix, or fully explicit, which is just when you pass information at the end of every time step. And we found that the semi-implicit coupling method worked well for the systems that we were looking at. It's stable. It doesn't add any additional computational cost to your Navier-Stokes simulation. And so you might be wondering, okay, why do we need to do this kind of multi-scale modeling? And this is a clinical example where having that feedback to the rest of the circulatory system is essential to correctly modeling this surgery. So this is the BT shunt that I showed you before. The surgeon goes in and puts in a shunt connecting the brachiocephalic artery to the pulmonary arteries. So essentially we're stealing flow, red flow from the systemic side and sending it to the lungs. Now clinically what happens is if the surgeon goes in and puts in a different sized shunt, the dynamics are such that it actually changes the cardiac output of the patient. And so this is an example of pressure volume loops produced from our model with 3 different diameter shunts. And so you can see that the work done by the heart has changed with these 3 different shunts. So if you try to just do the 3D simulation in isolation with these 3 different size shunts, then you would need to change the inflow boundary condition in response to having a different sized shunt put in. And without the lump parameter network, you wouldn't know how that would change. Another major challenge we've been looking at is that of uncertainty quantification. And so we'd like to know how do some of the errors in the inputs to our models propagate into the outputs. So for example, some uncertainty that goes into our model, there are many sources of uncertainty that go into these models. A few of them, we have noise in the image data. We might have user variability depending on who's constructing the model. We might have variable inflow rates. If the patient, if you measure the patient on a different day, you're going to get a slightly different value. The outflow resistances, the material properties, all of these things have uncertainty. We're interested in measuring from our simulation some kind of clinically relevant parameter. We're looking at wall shear stresses, energy loss, flow distribution, pressure levels, particle residence times, and those sorts of things. And these are quantities that we would like to put error bars on, depending on these inputs. We've been doing this with stochastic collocation. So we identify a set of input uncertainties. We construct a grid in the stochastic space that looks something like this. So this is, for example, with 2 stochastic dimensions. We then perform a simulation at each of these stochastic collocation points with that, whatever that set of parameters is. And we post-process this to compute PDF error indicators, confidence intervals, et cetera. And then this method is hierarchical, so you can then go back and refine your grid, increase the depth of interpolation, and continue this until you get a converged PDF. So this is a very simplistic example of how this works. This is an idealized model of an aneurysm with a bifurcation. So like an abdominal aortic aneurysm, you have an inflow. We assumed a 20% uncertainty in the diameter of this aneurysm. We then would, this is just a 1D problem, run a series of simulations at the collocation points generated for this dimension. We get a PDF of the output, In this case, we were interested in the wall shear stress in the aneurysm. And so this is a PDF of the wall shear stress. And you can see that as we increase the depth of interpolation, the PDF is converging to this one here. And from that, we can extract confidence intervals. So this is telling you, for example, that you're 99% confident that the shear stress in the aneurysm is between these two values. And obviously, this narrows as we go down to 90. Another major challenge in this area is fluid structure interaction. We have been doing this in collaboration with Yuri Basilevs in the structural engineering department at UCSD using an ALE method, which is a strongly coupled approach, like you mentioned. And so we're interested in how does wall deformation affect simulation results. In this particular example that I'm showing you, this is a model of the Fontan surgery. We found that adding FSI to the simulation had negligible effects on energy efficiency, pressure, and hepatic flow distribution, which I'll talk more about in a second, but had very large effect on the wall shear stress. And so it really depends on what clinical quantity you're interested in. If you're looking at thrombus formation, wall shear stress is going to be key to predicting that. If you're more interested in flow distribution, you probably don't need to do FSI. So I think this is highly disease dependent. This obviously has challenges such as uncertainties in material properties. It's very difficult to get patient-specific material properties, external tissue support, lack of patient-specific data.
Question.
Yeah.
Can you measure wall deformations with a very high-speed sequence, or?
You can measure wall deformations in MRI, and so there are people working on using like parameter identification tools to back out the material properties.
Okay, because that seems to be a critical component for the whole simulation.
Yeah.
Because it's very local, I guess, so you have these connections, and it might locally be very different. Yeah. So you would say you could get this data, or maybe not for every subject, but maybe as a model, which maybe represents.
Yeah, so it depends a lot on the type of imaging that they do. So, for example, a lot of the CT images we get are just one instant of time.
Yeah.
So then it involves going back to the clinician and convincing them that you want them to give you the time-resolved data, which is maybe not what they normally do. And so I'd say it's feasible, but not routinely done. Yeah.
Is it possible to get this information from ex vivo studies of vascular segments?
Yes. So there is data in the literature from people doing like tensile testing of pulmonary arteries. There's less data than you might think. So this is a source of frustration for my students when they say, well, I need to know the material properties of the pulmonary artery or the superior vena cava. And then I tell them to go look in the literature, and they come back saying, well, I couldn't find anything. It's like, well, maybe it doesn't exist. It's actually possible that it doesn't exist. We've done also some work in FSI in the context of devices. So this is a fully coupled simulation of a pediatric ventricular assist device. And this is similar to the Berlin Heart, which is actually the only FDA-approved VAD pump. And so in this device, we have an air chamber on the bottom. This is a pneumatically driven device. So the air chamber gets pressurized. It moves this membrane up and down and pushes blood flow through the device. So this is a displacement pump. And so we had some challenges in simulating this. We had to have two different fluids. We had to have a very thin membrane that has nonlinear buckling. And we did this with isogeometric analysis for the membrane and an ALE method. I've had a particular interest in optimization for quite a while. And so when doing optimization in the cardiovascular setting, we might be interested in, say, putting in a bypass graft, and then you want to know, well, what's the optimal angle that I should put it in at, what might be the optimal radius or positioning. And so we might have a number of shape parameters that we can define that describe our model. And then we need an automated way of having the optimization algorithm spit out a set of shape parameters. We need to then automatically generate the model, mesh it, run the flow simulation, and post-process it. And so we've been able to do this in an automated loop, and I'll show you that in a second. We're using a derivative-free optimization method called the surrogate management framework. It uses Kriging surrogate functions to improve efficiency, and basically consists of a search step and a pull step. There's quite a bit of convergence theory on this algorithm. It's one of the only derivative-free optimization methods that has an extensive convergence theory associated with it. But we are able to treat our function as a black box. And this is just an example of the mesh refinement that goes with the polling step. I'm not going to go into these details, but there are a number of papers here. I'm happy to talk about that afterwards. I just wanted to step you through a sample of how we might apply an optimization method. So we have a set of design parameters. We need to automatically generate the model. So here we might be interested in the anastomosis angle and maybe the radius and position of this attachment. So this is for the BT shunt model that I showed you before. We then need to produce that model via some script and mesh it automatically, and then run a finite element CFD solution on that model, which we post-process to produce a cost function value. And that cost function definition depends on whatever disease application we're looking at. So the cost function is going to be different for every application. We then give that to our optimization code. We construct some surrogate function, and we may do a polling step where we search neighboring points in the design space. Okay, so I now want to show you two clinical examples where we're applying all of these tools. And the first one is in single ventricle physiology. This is one of the most challenging diseases for pediatric cardiologists to treat. Essentially, the baby is born missing one of the heart ventricles. And so here's a case of hypoplastic left heart syndrome where the baby is missing this, or has a severely malformed left ventricle. So the first surgery that's performed is, there are a couple of variations. This is the BT shunt that I showed you before is one of them. This is another variation of the same one. The second stage surgery, they actually connect the superior vena cava to the pulmonary arteries here. So this takes the upper body flow and sends it, instead of sending it back to the heart, it now goes directly to the pulmonaries. And in the third stage, this is called the Fontan, they put in a Gore-Tex graft that connects the inferior vena cava. So this is all the flow coming from your lower body. And now this gets connected to the pulmonary arteries. And so what you have in the end is this rather different looking circulation where the blood flow now comes from the right ventricle, goes through the aorta. They've had to put in a patch to enlarge the aorta. It goes out to the body, comes back through the vena cava, and instead of going to the right side of the heart, right, because remember now we only have one ventricle, so we've had to completely separate the systemic and pulmonary circulations. So now the venous return comes directly to the pulmonary arteries without going back to the heart. And so we've kind of turned this two-pump system into a one-pump system where the flow just goes all the way around the circulation from that one pump. So there are a number of challenges with this physiology. These patients develop a number of problems. They can have exercise intolerance, arrhythmias, pulmonary arteriovenous malformations. Some of them get transplanted. Now, there was some early work on the Fontan junction. So when I'm referring to the junction, I'm referring to this connection here. So this is kind of a T-shaped connection that you don't see anywhere else in the body naturally. So people have looked at this experimentally. There was some important early work by this group in Italy looking at this computationally. And this early simulation work actually led the surgical community to change what they were doing. So initially, the surgeons were connecting the Fontan junction in a T where the superior and inferior vena cava flow impinged directly with these two jets coming directly towards each other, right? And so then the modeling showed that you could reduce energy loss by putting in an offset, so doing this, like the one shown here. And so the surgical community started doing this. Offset design, there's a potential drawback to the offset design, and that is that you tend to skew the flow coming from the lower body to one lung. And while that might not seem like a bad idea, it actually turns out that there's a liver factor that's very important for proper pulmonary development, and they refer to it as a hepatic factor. And if you're missing this hepatic factor in one lung, then the patient will develop arteriovenous malformations. So we proposed a new design that we hope will offer the benefits of both of these problems. So this is the original T-junction where you have these two impinging jets. And this is the offset design, which has been shown to reduce energy loss, but has this issue of skewing the flow distribution. And so we proposed doing this with a Y-shaped graft that would both avoid the impinging flow and distribute the flow more equally to both lungs. And so we've been testing this in simulations. We did virtual conversion, starting with these 5 stage 2 or preoperative models, and converting them with several different options, discussing with the surgeon sort of what he might actually do in the OR. And then we tested in simulation all of these variations, comparing the T, the offset, and the Y junction. And we were able to show that we did indeed improve energy loss and improve hepatic flow distribution. And we looked at rest conditions and exercise conditions and found improvement over the whole range of conditions. I would say that the the energy loss differences were rather small, and so we're now thinking more that the hepatic flow distribution probably will be more important, and I'll say more about that in a minute. We've done optimization on this model. This is an idealized model where we defined 7 design parameters, and we ran optimization on the hepatic flow distribution to look at whether it might be advantageous to use different sized branches in some patients. So you may have some patients with varying pulmonary resistance, and so in those patients, we thought it might be advantageous. It turns out in optimization, we were able to show that we could achieve the optimum with either equal-sized or unequal branches. And so we actually don't think that it's a good idea to use unequal branches based on our optimization results. This is an example of an underperforming patient from our initial study that we were able to improve via optimization. So this is the Y-graft result with about a 70-30 flow distribution. We'd ideally like to get that to be 50-50. And so what we did was we extracted sort of the key features of the patient-specific model. We performed optimization on this, what I'd call semi-idealized model, using the SMF method. We were able to identify a graft design that got us very close to 50-50. This is the idealized model. We then took that graft design and put it back into the full patient-specific model to confirm that we got a result very close to 50-50. And so we were able to take that underperforming case and improve the result. We've also put the Y-graft into this multi-scale loop that I was showing you before, and this allows us to look at things like how is the workload on the heart affected by changing this model. So we put in these 3 different designs, and we got a kind of surprising result out of this, which is that the workload on the heart actually didn't change. So these 3, this is the pre-surgery one, this is an exercise condition. So these 3 lines are all exactly on top of each other. So all the thinking in the field up to that point had really focused on the energy loss as the key parameter. And here our multi-scale model is showing that we actually don't see any difference in the heart workload, which is sort of an intuitive result if you go back and think about it, in that the resistance difference in the 3D model is so much smaller than the overall resistance of the entire circuit that it's just not enough to move the needle.
And why not go back to the T-junction?
So we have actually showed that the Y-graft improved the flow distribution compared to the T-junction. So I still think, based on the hepatic flow distribution, that it probably offers an advantage. It depends on the pulmonary resistance of the patient. So our thinking is that we should identify the patients who are best candidates for either of those 3 designs. Probably the Y-graft is not the best choice for every single patient, but we'd like to have a tool that could identify the best choice. Yeah. So the Y-graft design has the disadvantage that it's more technically difficult to perform, and there's a little bit more suturing involved. But probably over the long run, that's not that big of a problem. We've actually achieved clinical translation of this design. So there's a heart surgeon at Stanford, Mohan Reddy, who's actually tested the Y-graft in 6 patients now. This is a picture of him constructing it in the operating room, and this is a picture of it implanted in the first patient. So the purpose of the pilot study was just to demonstrate technical feasibility of the surgery. We've since collected post-operative image data on the patients. So we demonstrated technical feasibility. All patients are asymptomatic. We did have 1 negative result, which is that we had thrombus formation in the branch of the Y-graft in 1 patient, and we're now investigating. We think, going back and looking at the history, we have an explanation for why that happened. We were also able to compare our simulation predictions with lung perfusion data with quite good agreement. And so this is an example of validation against actual clinical data, which is very difficult to get clinical data. So I'm almost out of time, so I'm just going to really quickly go through the Kawasaki example. This is another disease we've been working on in collaboration with medical school folks at UCSD. Kawasaki disease is actually the leading cause of acquired heart disease in children. These are some of the symptoms. The reason we're looking at this disease is that there's a risk of coronary artery aneurysms in these patients. And this is an image of a patient with aneurysms in their left coronary. And the reason that we're looking at this is that clinicians are faced with difficult choices in managing these patients. So one of the choices they have to make is whether or not to put the patient on anticoagulation medication. And currently, the way they make this decision is they image the patient, they measure the diameter of the aneurysms. If the diameter is greater than 8, they put the patient on anticoagulants, and if it's less than 8, they don't. They watch the patient over time. We know that there's an infinite number of ways you can create an 8-millimeter diameter aneurysm, and the flow patterns are going to be very different in all of those aneurysms. And so we're interested in seeing if simulations can do a better job at predicting the risk of thrombosis compared to just using the diameter, which is what they're doing now. We can get imaging information from CT, and then we're performing patient-specific models of these different aneurysms to see if we can do risk stratification. And so this is an example of different models we've constructed from CT data. These are all Kawasaki patients with aneurysms, and this is a Kawasaki patient who had normal coronaries that served as our normal control. Okay, so you can already see that there's huge variation in the geometries of these aneurysms. There are many different ways to get an 8 millimeter diameter. We modeled this using the lump parameter framework that I talked about before, with a specialized coronary boundary condition that has a variable pressure to model heart contraction. So coronary flow is difficult to model because when the heart contracts, it changes the downstream resistance, and coronary flow is actually maximum during diastole. And so if you just use a standard boundary condition, you don't capture that effect. So like I said before, we're solving this coupled system with Navier-Stokes and the ODE governing that coronary model. And then we can look at things like wall shear stress distribution. And this is showing two of the patients, A and B, versus the normal model. And you can see that the shear stress in the aneurysmal regions is about an order of magnitude lower in the patients with Kawasaki disease compared to the normal. And in this case, it was particularly pronounced in the left coronary artery. This is a movie of the wall shear stress as it's varying with time. And the main thing that you should notice from this movie is that patient A has low shear stress, but then the shear stress is higher through part of the cardiac cycle, indicating that there's some washout of the aneurysm, whereas patient B has low shear stress that just persists through the entire cardiac cycle. And so just based on this, we would tend to think that patient B had a higher risk of thrombosis, but our goal is to ultimately correlate these with clinical outcomes. And so patient A, this is an example of particle tracking, so looking at particle residence times inside the aneurysms in patient A and patient B. And again, you see that patient B had very slow, sluggish flow down the length of the aneurysm. Our ultimate goal is to gather all of this data and try to create a clinical index by correlating some of these simulation-derived quantities with patient outcomes. And so these are some of the quantities we've looked at so far, and there are others as well that aren't on here, but as an example, you can see the particle residence times in patient B were the highest of all of the models that we looked at. And then we have just a yes or no indication of whether the patient had thrombosis or heart attack. And so we'd like to use statistical correlation to correlate these quantities with the outcomes and figure out which of the hemodynamic quantities are most predictive. It turns out that after we did the simulations, patient B actually developed thrombosis in both left and right coronary arteries and had to go for bypass surgery. My grad student was a little freaked out by this. He'd been doing these simulations. But here you can see the correlation between, this is the location of thrombus formation. This was our simulated wall shear stress. And here's this is the left and this is the right coronary correlating with areas of low shear. And that was also the patient who had the lowest shear of the group that we looked at and the highest particle residence times. We divided the patients, those patients that I showed you, looking at aneurysmal versus normal. We, of course, see a huge difference in flow conditions. This is showing difference in wall shear stress between aneurysmal, which is about an order of magnitude lower than normal, and particle residence time, which is much higher in the aneurysms compared to normal. So this result is fairly intuitive. What I think is more surprising or more interesting to us from a clinical point of view is when we divide the patients into those with aneurysms who went on to develop thrombosis and those with aneurysms who didn't develop thrombosis. And there we look at differences in wall shear stress, and we see reduced shear stress in those that developed thrombosis. We see elevated particle residence time, but the diameter is not very different. And this is the measure that clinicians are currently using to distinguish in risk between these patients. And so we believe, at least based on this preliminary data, that hemodynamics are likely a better indicator of the risk of thrombosis compared to just the anatomic measurements that they're using now. We don't yet have enough patients to achieve statistical significance on this, and so we estimated by power analysis that we probably need about 100 patients. And that's what leads us back into some of the challenges with image segmentation and sort of what happens when you need to include 100 patients or more in your study and you have a grad student or undergrad spending hours and hours segmenting all of these models. Yeah.
So do you think if you were able to validate that the hemodynamic analysis is appropriate, that you could then go back and try to figure out whether image-based ways of inferring wall shear stress, although they're not.
Yes.
They're not accurate. I mean, diameter comes easily from imaging. They can attempt to infer wall shear stress with a little more effort and possibly have a non-invasive and rather fast.
Yes. So ultimately, I think if we build up a database of models and possibly CFD results, we could do some sort of reduced order model to extract without having to do a new simulation for every patient who came in. Because I don't think it's going to be, at least not in the immediate near term, practical to do a CFD model on every patient. But yes, I think if we do a better shape analysis and look at how that correlates with shear stress, that we could get similar. Yeah, yeah.
So, sorry.
Yeah, go ahead.
What you said, so why do you think it's not feasible? Is it just computation time, or is it user time, or segmentation? Why can't you do that for every patient? Is it just
Okay, so there are, and particularly one company started by Charlie Taylor that is attempting to do patient-specific modeling and simulation for every patient that comes through. This particular disease is relatively rare, and so I think it might be possible to do this on the academic side as a research tool, but commercializing it for Kawasaki patients is probably not feasible currently. If you set up some sort of core lab or something that could process patients, it might be possible. You don't need to do this in an emergency setting. You have some time, so if you take a few days to turn it around, it's not a problem. It's more setting up the infrastructure to do the modeling on a patient-by-patient basis. I don't think it's possible. I don't think it's realistic to ask clinicians to run a CFD simulation for every patient. And so you need to set it up more as a central facility that could process them all. Yeah, so it's a question of resources, I guess. Okay, so I just wanted to summarize. I showed you some tools for multi-scale modeling for optimization. We've developed a Y-graft for the Fontan surgery that I think is promising and has been translated into clinical use. And we also reported the first quantitative data on hemodynamics in Kawasaki patients with coronary aneurysms. And we're hoping to use those simulations to develop a clinical index that can help clinicians better decide who to put on anticoagulant medication. In all of this work, there is much more need for validation. We have some collaborators who are setting up in vitro mock circuits, and we compare very well with the in vitro data, but getting the in vivo validation data is an ongoing challenge. I showed you a little bit of that, but there's a need for much more. And all of this work requires extremely close interaction with clinicians who are seeing these patients on a day-to-day basis. So it's not possible to do this without a really tight partnership with clinical collaborators. A couple of future directions that I think the field is sort of moving towards, things like incorporating growth and remodeling, incorporating more detailed models of thrombus formation, looking at endothelial response. We're particularly interested in how to do patient-specific model parameterization so we can do optimization directly on the patient-specific models. And then looking at coronary bypass grafting, vein graft remodeling, optimization of devices, things like that. And these are my acknowledgements. This is my group in San Diego. A number of clinicians, particularly Jeff Feinstein and Jane Burns. Jeff is at Stanford, Jane is at UCSD. Andy Kahn did the imaging of the KD study. So thank you. Happy to take questions.